Every so often you read about something that feels like a genuine turning point. And I think this is one of them.
It really is. We're not talking about a small step here.
No, exactly. Scientists have managed to engineer a new class of drug that, it operates like a microscopic, highly personalized, targeted missile.
That's the perfect term for it.
And it's designed to hunt down and destroy cancer cells while mostly leaving everything else alone. This feels like it's fundamentally changing how we approach the disease, offering a whole new kind of hope.
It's a conceptual leap. It truly is. We're moving beyond, general poisons like traditional chemo, and even beyond those first-generation targeted drugs.
Right.
We are now firmly in the era of delivering these incredibly potent, localized weapons directly to the cellular structure we need to get rid of.
Exactly. So our mission today is a deep dive into these revolutionary compounds. We want to understand, and quickly, what they are, why they're such a huge leap forward, and most importantly, how this biological GPS system actually works inside the body. The clinical community calls them ADCs, which stands for Antibody-Drug Conjugates.
Antibody-Drug Conjugates.
And that nickname you use, targeted missiles, is it's completely deserved. They're a relatively new type of anti-tumor medicine developed over the last few years, and they are engineered for just unparalleled precision.
It's like biology meeting chemistry.
It's the perfect merger. You have highly specific biology, that's the antibody, combined with traditional, very potent chemistry, the drug payload.
Okay, so let's unpack that right away. Because, targeted therapies already existed. Why did scientists need another new drug type? For years, we were told those were the precision weapons, right? The key to avoiding all that awful collateral damage from chemo. What was their flaw? That is the essential question, and it's where we have to start. The previous targeted drugs, they worked by binding to specific molecular structures, we can call them target points or receptors, on the surface of cancer cells.
The lock and key idea.
The lock and key idea, exactly. And the idea was sound. If only cancer cells have this specific lock, then a specific key, the drug, should only affect them.
So in theory, if a breast cancer cell has a ton of, say, receptor X on it, you hit it with a drug designed only for receptor X. Clean, simple.
In theory, yes. But the clinical reality was a lot more frustrating. The real limitation was efficacy, and it all came down to something called target expression.
Meaning how much of the target is actually there?
Precisamente. A cancer cell might express these targets, but the concentration, the number of locks on the cell surface, might not be high enough. And if that expression level was low, the older drugs just couldn't bind strongly enough or in high enough numbers to actually kill the cell.
So the targeted drug would sort of float by, see a faint signal, but it couldn't get a strong enough grip to do its job.
That's a great way to put it.
And the result is the cancer cell, even though it's technically a target, it just survives.
It survives. And in oncology, as you know, a cancer cell that survives treatment often means the tumor progresses, or worse, it becomes resistant. So this limitation meant a lot of patients, even those whose tumors technically had the target, they didn't really benefit.
So you had a good drug, but it needed this super strong signal to work.
It needed an overwhelming concentration of those receptors. If the target was weak or sparse, the drug was largely wasted.
So that raises the big question then. How do you deliver a powerful punch, a really lethal dose of toxicity, even when that cellular target signal is faint? You still have to kill the cell.
The answer they landed on was just incredibly clever. It was a total paradigm shift. They decided to stop trying to make the key itself the weapon. Instead, they decided to use the key purely as a sophisticated delivery truck. A truck to drop off a payload that is so destructive it doesn't really matter how faint the initial binding was as long as it gets inside the door.
And this is where it gets really, really interesting, because the solution is essentially modular. They figured if the antibody, the targeting part, isn't toxic enough on its own, let's just use it to carry something far more destructive. Let's get into that mechanism, this small car and bomb analogy.
It's a perfect analogy. It really captures the three core components of an ADC. So you start with a monoclonal antibody, that's your small car.
The GPS system.
The GPS system, yes. Its only job is recognition. It has to find and stick specifically to that chosen target receptor on the cancer cell surface, nothing else.
And then component number 2 is the bomb.
Correct. That's the cytotoxic payload. It's usually a very powerful chemotherapy drug or another toxic substance. And often these are compounds that are they're way too potent to be given to a patient. Normally, systemically, they'd cause massive collateral damage.
So these ADCs make these otherwise unusable drugs viable again.
They do, but the whole system, the whole thing, depends on component number 3, which I think is maybe the most sophisticated piece of engineering here. The linker.
The linker. That's the chemical tether that holds the CAR and the bomb together.
Absolutely. The linker is the unsung hero, the safety mechanism on the missile. It has to be incredibly stable while the ADC is traveling through the bloodstream, through healthy tissues. It has to make sure the bomb doesn't just fall off early.
But then, once it gets inside the cancer cell, it needs to break instantly. That's the time detonation.
That's the time detonation.
Wait, hold on. If that toxic drug is so powerful, what guarantees the linker stays stable until it's actually inside the cancer cell? What stops the bomb from detaching early, while the car is still on the highway, risking damage to healthy organs?
That is the million-dollar question. And it's what separates a successful ADC from a failed one. It took years of chemistry to get this right. The linkers are engineered to exploit the environmental differences between the bloodstream and the interior of a cancer cell.
Oh, clever.
Very. Many of the successful ADCs use linkers that are sensitive to specific conditions. For example, a much lower pH, a more acidic environment, or the presence of specific enzymes like proteases that are often overexpressed inside the cancer cell.
Okay, so the antibody gets taken inside the cell's own machinery starts trying to break it down, and in that process, it accidentally cuts this sophisticated linker.
The cancer cell essentially consumes the delivery vehicle, and only then does the bomb drop directly into its cytoplasm.
Oh.
And that's the successful conclusion of the mission. You see how this just shifts the focus entirely. Traditional chemo was a systemic, broad-spectrum attack. It was like carpet bombing, right? All the terrible side effects, hair loss, nausea, bone marrow suppression, that was unavoidable because the drug attacked all rapidly dividing cells, healthy or not. Now, with ADCs, you achieve highly precise, targeted destruction. You use the antibody's amazing recognition ability to sneak the toxic payload past healthy tissue, making sure that lethal concentrations of this poison are released only inside the tumor cell. The receptor isn't just a flag anymore, it's the key that lets you open the door to detonate the cell from within.
That's a massive improvement in what they call the therapeutic index.
A massive improvement.
It sounds like an incredible feat of engineering, really.
No.
Merging the specificity of immunology with maximum lethality. So
Yeah.
what's the status now? Are these things still theoretical, or are they making a real impact for patients?
Oh, they are very much a clinical reality. While, yes, many ADCs are in clinical trials for new targets, a significant number have already entered clinical practice. And they are providing genuinely compelling results for patients with cancers that were historically very, very difficult to treat. It's one of the fastest growing fields in oncology today.
So when we look at these clinical success stories, which target has been the most effective so far for these targeted missiles?
One of the foundational successes, the one that really proved the potential of this technology, centers around a target called HER2.
HER2, right? We hear about that a lot. Historically, very challenging. It's often overexpressed in aggressive types of breast cancer or gastric cancers. So how does the ADC mechanism play out with a HER2 positive cancer cell? Can you walk us through that sequence?
Sure. The sequence is, it's elegant, and it's perfectly designed to overcome that low expression problem we were talking about. So first, you have a monoclonal antibody that is specifically built to recognize and target the HER2 receptor.
Okay.
And this antibody is chemically linked to a highly potent cytotoxic drug.
So the whole ADC complex is in the circulation, and it's just seeking out HER2 like a homing beacon.
Exactly like a homing beacon. When the ADC reaches the cancer cell surface, the antibody part binds tightly to the HER2 receptor. Now, here's the crucial step. Unlike the older drugs, the goal is not just to block the receptor from the outside. The cell senses that its receptor is bound, and through a natural process called endocytosis, it actually internalizes the entire complex. It basically invites the delivery truck inside the loading dock.
It literally opens the door for its own destruction.
Precisely. And once inside these little compartments in the cell endosomes or lysosomes, the environment changes. The pH drops, those specific enzymes we mentioned are activated, and this acidic enzymatic soup triggers the cleavage of the linker. The bond breaks.
And the bomb is released.
The highly potent toxic drug component is released directly inside the cancer cell.
Right into the cytoplasm at maximum concentration. I mean, that has to be just devastatingly effective. The cell has no defense against that kind of sudden internal attack.
It ensures the required lethal dose reaches its intended victim, while the exposure to healthy surrounding cells is minimized. And the impact on clinical outcomes, particularly for HER2 positive cancers, has been, well, it's been transformative.
Let's talk about the clinical benefit for a second. that internal release must drastically reduce the harsh systemic side effects we associate with chemo, doesn't it?
It absolutely does. I mean, think about the patient experience. Before ADCs, treating these tumors often meant using traditional chemo alongside targeted agents. So you are still suffering the total body exhaustion, the nausea of the chemo. With ADCs, we're still using potent chemotherapy, but we've managed to localize the toxicity.
So patients feel better during treatment.
We see significantly reduced systemic toxicity, less hair loss, less immune suppression, because that highly destructive agent is only activated in large amounts once it's already inside the tumor cell.
That is the ultimate trade-off, isn't it?
Right.
Delivering maximum killing power exactly where you need it, while leaving the rest of the body relatively untouched. It's a revolution in patient quality of life.
It is. For patients whose tumors express HER2 positivity, this approach has achieved just excellent therapeutic effects. It's specifically solved that historical problem. Even if the HER2 expression wasn't overwhelmingly high, just using that receptor as the delivery address for an internal explosion has dramatically improved patient outcomes.
So bringing all these takeaways together, what this all really means is that ADC drugs have found a way to deliver maximum toxicity with minimum collateral damage. They solved that low target expression problem by changing the target's role. It's not just an identifier anymore, it's the front door.
It's the ultimate Trojan horse. You're using the cancer cell's own growth signals against it. The cell puts out a target protein, thinking it's for its own function, and instead that protein just becomes a personalized mailbox for a lethal payload.
It forces the cell to commit suicide.
In a way, yes. We're going from broad-spectrum medicine to pinpoint surgical stripes at the cellular level, and the results are they're undeniable.
So what's fascinating here are the implications for the future, right? Beyond just HER2.
Oh, absolutely. The success is rooted entirely in delivering that drug directly inside the cell for this highly localized destruction. And that raises a really important question for you to think about. Considering how successful this has been, how might this change the way we treat cancers that have historically evaded our therapies?
Cancers we used to call undruggable.
Exactly. Many of those cancers are undruggable because their defense mechanisms are excellent at pumping out external toxins. But if you can breach that defense with this kind of internal delivery, what other previously impenetrable cancer types might now be vulnerable to this kind of cellular precision bombing? That is something for you to mull or explore on your own.